We have a full program today, so I'm going to go ahead and get started on time here. The purpose of this talk today is to provide an overview for the Regenstrief Center for Health Services Research. And this is for multiple audiences, other centers or services at the Institute, those who are new, who don't know everything that's going on, and for faculty and for professional staff. So I hope everyone gets something out of this talk. Here's an outline of our presenters. We have a lot of information to share, and I'll be getting a lot of help sharing this information from others in the center who will share their portfolios and programs of research. So I've asked everyone to stay on time with 7 minutes, but we have a good problem that there's more information than we can share in an hour about our center, but we'll at least start here today. So at the outset, I'm going to ground ourselves in some of our mission and vision statements. I know the Regenstrief mission statement has been undergoing some evolution, but a current statement is, we come from many disciplines and backgrounds, united by the commitment to effectively translate discovery into equitable healthcare access and health outcomes for patients, families, and communities. So we hope and believe that in our Center for Health Services Research that in our vision of several years, we align well with this mission. And that includes improving the delivery and outcomes of healthcare through innovative research on health information, equity, technology, and communication. So the research areas highlighted here highlight the interdisciplinary nature of health services research, and also the way it enables us to answer important questions and questions we really care about in healthcare delivery. So methods may include implementation science methods, mixed methods research, and also some areas of broad interest. And although we're not a disease-specific or service-specific center, in some of these areas we also have deep expertise as people have developed their programs of research. So that includes in quality and access to care and transplantation services with Dr. Patzer and her group, and cerebrovascular disease that the VA query has been doing for several years. We also have expertise in care coordination in cancer and peripheral vascular disease, health equity research in chronic pain, special groups like LGBT populations, and special problems like social isolation. We also have a unique niche in human factors and HCI methods, and have done studies assessing patient portals, health information exchange, and other technologies. And then finally have done evaluations of community-based health services, especially related to mental health recovery and infant and maternal health. So this is our leadership team, including myself. Our Associate Director for Data Science is the title, Andrew Gonzalez. He does many other things, including leading an early career writing group, serving as a liaison with the Surgical Health Services Research Group. So I appreciate all of Andrew's contributions, as well as with the rest of our leadership team, which includes Losee, who's the Director of Center Operations, and Donna Burgett, who is our administrative team leader. So in terms of who is HSR today, among our research scientists, we're fairly evenly divided between physician scientists and PhDs. We represent multiple schools at Indiana University, including at least 7 divisions or departments in the IU School of Medicine. We also have open positions that we're recruiting to currently in the Division of General Internal Medicine. In addition to our scientists, we have multiple training programs. Our faculty can't be mentors without mentees. And then, of course, to do the work that we pursue, we rely on our skilled professional staff, and they're essential to the teams that conduct the research, and we operate in a true spirit of team science. So with regards to our investigators, we're very diverse and broad in our research interests and backgrounds. And in a brief talk, I thought the best way to represent that would be with this picture. Researchers who have joined HSR in the last year include some senior leaders, including Dr. Bill Amoria, the chair of the Department of Surgery, and of course, Dr. Patzer, our new president. We also officially appointed, together with CVMI, Bill Tierney, who many of you know, of course, and who is the namesake, in fact, of our Center for Health Services Research. And then also we're very excited to have the investigators, Drs. Ross Driscoll and Dr. Drury, who've joined us. If you haven't had the opportunity to meet them yet, I hope you are able to in the coming months. We have, here are postdoctoral fellows. We have multiple training programs, including a surgical HSR fellowship, which we conduct together with the Department of Surgery. One of our newer VA training programs is an advanced fellowship in the learning health system. This is administered by the VA together with the help of Academy Health, and we've recruited 3 new fellows to that program since 2022. Jill Inderstrad is our current VA Medical Informatics Fellow, and then we're also hosting a postdoc from the IU Kidney Disease T32 program led by Sharon Moe, Dr. Catherine Kelty. So here's a listing of our affiliate scientists. You can find more of this information on the Regenstrief intranet. These are individuals who collaborate with investigators or teams in our center. And these represent people who are interested in working more closely with the Institute and being a part of our community and scholarship activities. So of course I can't, again, describe all of the research in our center today, but I want to describe some of it. And some of the things I was going to highlight today are related to high priority or emerging themes at the Institute more broadly. That includes in health equity research. I would highlight some of the work that Drs. Matthias and Eliasson have done together. They very recently published the results of a randomized intervention trial that was conducted among Black patients with back pain, and with the telephone-based communication intervention sought to increase activation and self-efficacy in pain management, and this was a positive trial. They were also busy during the pandemic, and as a part of a special project, were able to collect qualitative data about healthcare access and delivery during the COVID pandemic for Black veterans with chronic pain. Dr. Eric Vachon was a key investigator and member of a team that recently published a randomized intervention trial in JAMA Network Open that compared the effectiveness of 2 interventions to increase breast, cervical, and colorectal cancer screening. This was done among women in the rural United States, especially Appalachia. I also wanted to highlight some of the implementation science and high impact work that's being done in our center, including in the VA. Dr. Linda Williams has completed a few projects related to the VA National Teleneurology Program. One, implementing teleneurology to improve equitable access to outpatient neurology care, and then also a mixed methods evaluation guided by the REAIM framework. I'm also highlighting here some of Dr. Bravada's thought leadership. She has been a leader in stroke care delivery and actually leads an annual update that's conducted by the High Impact Stroke Journal, where they update advances in quality improvement work. Their most recent update had an interesting finding related to the need for more research in scaling stroke care quality across health systems and rural environments. Dr. Bravada has also published about stroke learning health systems, and you may be interested in a commentary related to artificial intelligence that she's done in stroke as well. So I'll go through some of the Traditional metrics for our center, we have 12 active NIH projects currently, and that includes 7 R01s. We also have a very robust VA research portfolio, and our VA center is, in fact, Center of Excellence is undergoing its renewal early next year. And then we have a diversified portfolio that includes support from industry, foundations, and others. So this is a picture of our 5-year funding history. I received this information fairly recently, and this is something we're still working at the Institute to assemble in new ways. I mean, some of the main points I'd make is that we want to benchmark our progress, that we want to seek for a match between our output and our capacity, and finally, we want to seek ways for growth over time. And then here's a quick snapshot of our publications, which is very respectable output. It jumps in the last year because I believe communications has gone about identifying publications in a new manner where people don't necessarily indicate their Regenstrief affiliation in the publication, but clearly a jump there that is consistent with other data from the Institute. So I'm just going to spend my last couple of minutes talking about our strategic goals for 2023 and beyond. I think we need to leverage and take advantage of strategic research opportunities, including in areas we've been working on, and the Institute is seeking more work in the future, including health equity research and implementation science. I think there's also unique opportunities in cancer health services research. We have 3 active NCI R01s currently in our portfolio. And there also are new opportunities in using large data sets that are being acquired, such as from CMS and others, to answer questions of interest. We also want to deepen our partnerships and collaborations to support our research enterprise. That will include things like doing more implementation science and healthcare systems like IU Health and Eskenazi, extending our collaborations and networks with other health services researchers like in surgery, pediatrics, and emergency medicine, continuing to sustain our partnerships with VA HSR&D and Query, and we'll hear from both of those programs during our panel here today. As well as new partnerships with groups like the IU School of Public and Environmental Affairs, which Dr. Cosley Simon is a part of, and the Schools of Public Health, both here and in Bloomington. We'll seek to continue to grow our HSR portfolio and its impact. We'll focus on goals for NIH funding that the Institute has, as well as other federal funding in strategic areas. And we also want to participate in the ongoing process of defining, measuring, and ultimately achieving impact. And then last but not least, we need to continue to pay attention to our research culture and capacity. This includes building research skills in both faculty and staff through training, mentoring, and the individual research projects we work on together. We also want to recruit excellent faculty, fellows, and staff, and Lori Losee will talk a little bit more about our professional staff activities and opportunities in a moment. I just want to promote briefly before we transition, our HSR work in progress that takes place Fridays at 11 in the morning. Anyone is invited to participate or even present. Jennifer Carnahan from IU CAR presented this last week, and we really enjoy the cross-center and interdisciplinary dialogue that takes place there. So thank you, and we'll transition away.
Thank you, David. You're setting a good example of timeliness for presentation, so it'll keep us all on time today. Thank you to all who are in the room and those who are joining us remotely. It's a real honor to talk about the complement of the team members in our center that help drive our work forward every day. You don't often get to see us all in one place, so I thought you would enjoy taking a look at all of the members, including newer members that are in our center. We're especially proud of the expertise that they bring to our projects and our operations, and also their individual achievements that we celebrate. Every day, this is the group of people that helps drive our research enterprise in partnership with our principal investigators. So we are very proud of that group. This is just demonstrating some growth that we've experienced, which is some rapid growth in this past year. These are individuals that joined us in the fiscal year 2023. And we welcome them, all of them, into our center. And also staff who have advanced in their careers in the last couple of years. We're anticipating more in the new year to come. The positions that you'll find in the Center for Health Services Research track very closely to our collaborators in the Center for Aging Research, with the majority of them being represented in the research assistant category, research specialists, and research coordinators. And reflectively, I think it's interesting that the same kind of professional diversity that you see in our principal investigators who come from all different backgrounds, it's the same is true of our staff. So they bring a wealth of experience with them when they join the center, coming from all kinds of different academic areas that are represented. I think I've captured most of them, but I'm sure that there's one or two that I'm missing here. Also, many of our research specialists, coordinators, and managers go on to pursue professional certification in different areas. The two that are most strongly represented in health services research are those pursuing certification in clinical research management and also professional project management. I'm going to spend just a few minutes on each one of these slides, actually 1 minute each. They're going to go by very quickly, but I would welcome conversation and more dialogue with any of you regarding culture. It's something that we think about a lot in the Center for Health Services Research because we spend a lot of time at work. All of us spend a lot of time at work. And so the environment in which we work is really important to us on a daily basis. We invest in continuous and ongoing learning as a center, and we also leverage much of the training opportunities that are available through our partners at the university, including CTSI and other departments that are offering training, and then some external groups that we also work with. We have a strong qualitative core in the Center for Health Services Research and pursue training in qualitative methods as well for our staff. These are examples of a couple of training opportunities that are coming up that will be open to everyone at the Institute and our partners on campus. Some may have seen an announcement that went out recently about an upcoming in-person workshop on real-world recruitment of research participants. I didn't practice that before reading it. And then a second one on implementation research. That's a working title. It's probably going to change, but these should be hitting your inbox in the upcoming week to 10 days. In addition to learning, we are really purposeful about networking in our center. And as with all of us at the Institute, we've been experimenting with ways to increase our opportunities to connect both spontaneously and in purposeful ways. So David has already presented one. Our HSR WIP is a long-held tradition that many people participate in. It's a great way to learn about our science and ongoing work. We have a monthly all-staff meeting where we talk about professional development and other topics. We troubleshoot, we do knowledge sharing across projects so that we're not always inventing the wheel every time we try to solve a problem. CHSR Networking Wednesdays has been a success. So we are seeing more people in the center and in person on Wednesdays, and that's been a fun really fun, spontaneous way to interact with each other. Our supervisors have a monthly roundtable where we're covering topics related to human resources and managing and leading. We also have investigator forum meets monthly, and then we have pop-up water coolers occasionally that are topic related. Anybody can call one, it's usually me, but it provides us a chance to interact in quick and spontaneous ways. All of these venues, for the most part, are available in a hybrid setting, so we're able to involve both our remote participants and then those in person as well. Outreach and wellness are important to us, and we are always looking for ways to provide value-added spontaneous engagement within the center. We enjoy our cross-center activities when we can. Ice cream was awesome on Monday, as well as our town halls. In CHSR, we're doing some things like doing outreach at a recent colon cancer run. We have a committee that works on outreach and wellness as champions, and they're coming up with new ideas for us in the coming year ahead. We also have members that are serving on the Regenstrief DEI Council. We did a small food drive this year that we're really proud of. And then also just in the interest of promoting wellness for our community, we've adopted a HSR outside program. We did that during COVID. We did that a lot during COVID, and we're looking for opportunities to do that more in the months ahead. And with that, I will turn it over to our next investigator presenter. That's Matt Bair. Thank you.
All right. Thanks for the handoff, Lori. All right. Good afternoon. We're going to talk about some veteran-focused research and impact. So I want to just frame it as sort of our past, present, and future of our VA center. So our center is the Center for Health Information and Communication. So in the past, this had been our mission statement, advancing healthcare for veterans through health information, technology, and communication. And this has been our identity for many years and what people recognize us. We are in some evolution as we are applying for renewal and some change of leadership. So we have many key areas here, and I think what this shows is how diverse our interests are, how diverse our expertise from cancer prevention, survivorship, coordination of care. We research chronic pain, including opioid prescribing. We look at electronic clinical quality metrics. Health communication is a big emphasis for us, especially at the patient-provider level. Medical informatics is a strong interest of ours, as well as medication safety. Mental health is a strong focus for us, including serious mental illness. We also have some interest in preventing provider burnout. Stroke, as Dr. David has mentioned, stroke is a strong force. We have strong interests of ours, as well as cross-cutting interests in implementation science. Some of our new and emerging areas are in telecare delivery, COVID-19 effects, and health equity. So in present, you may be aware we've had a leadership transition. Just want to thank Mike Weiner's outstanding and selfless service as our center director for the last 13 years, and he's passed the torch on to me just recently, October 1st. So thankfully, we have a lot of stability. We have a lot of leadership acumen, as Angie Rawlings being our associate director and our admin team, which is great. Our leadership team is really staying intact. So we want to win. I mean, what's important now? I use this acronym a lot. So what should I be working on now? And there's a lot of important things that we should be working on now, but maybe it should be what's incredibly important now is that we are, reapplying for the next iteration of our VA center. And so we've been undergoing planning and discussion meetings, preparing some drafts, arranging reviewers. So thank you to the reviewers that have accepted our invitations. and we will submit this application in March of 2024. So we've as we're working on our reapplication, we've sort of looked at our projects and our investigators over at the VA in kind of broad areas and specific projects currently where we have effort and sort of center of gravity. The 4 big areas are in pain and opioid use disorder, and you see the investigators that are in that area. David really highlighted nicely our work in health equity and social determinants of health area. Again, with strong interest in mental health and substance use disorder, and more of an emerging role in the area of aging research. So I'd really like to brag about our center and some of our recent accomplishments. We've had a lot of recent accomplishments, but a couple I really want to highlight. First of all, Teresa Damish and Marianne Mathias being recently named as VA Research Career Scientists. This is within the VA as an outstanding honor that sort of recognizes their sustained excellence in research. It's basically like a mid to later career development award, providing salary support and funding. So it's outstanding. So if you see Teresa and Marianne, we'll hear from Teresa later. Please congratulate them. Kind of hot off the press just this week, we've had notice of intent to fund Jenny Marat's HSR&D Career Development Award addressing under and overuse of colorectal cancer or colorectal neoplasia surveillance among veterans. And also Joanne Eliason, who has a notice of award for HSR&D merit review, which is the VA's RO1 equivalent, increasing veteran social engagement and connectedness, called Connected. So in the future, I think the future is our new investigators, our fellows, our newest investigators to Sheik Sally Wasmuth, and you see her very interesting work in creative arts, looking at narrative-based cultural humility training to ensure affirming care for transgender and gender diverse veterans across services, a pilot feasibility. So this is a HSR&D pilot award. And then Sarah Shu and her HSR&D pilot as well, called Pilot Testing, a virtual mindfulness-based intervention aimed at improving reintegrating veterans' health outcomes. So one of our primary goals is to build upon our investigator ranks. That's certainly an effort that I will be putting a lot of time into. So also part of that, and David had really highlighted our fellowships. Our fellowship programs have been really a key to adding to our investigator ranks, probably our most effective recruitment goals through our fellowship programs that then eventually become core investigators at our center. And so you've heard about Coco Grant and Christine Wiles and Madison Stout that are our current fellows in the Learning Health Services Fellowship that are directed by Teresa and Marianne. We also, directed by David, he didn't talk about this, but he didn't sort of brag about it, but David leads our medical informatics program where Jill Inderstrad is our current fellow. Maya Story was an informatics fellow and recently transitioned to our COIN scientist. So really been, this is our future, our newest investigators. I'm going to give slide creds to Angie Rawlings, who created this. So when we need to really be responsive to our funder, and our funder is VA Health Services Portfolio or VA Health Services Research. And what this shows are what are the VA's priorities in research. And, and in red, and some of the growth potential you see in green, and you see in sort of the lightning bolts where we have a lot of sort of center of gravity and current projects in those areas of chronic pain and opioid use disorder, health equity, and social determinants of health. Not only we have strength, but it's also a really strong growth potential for us in that area. Mental health has traditionally been very strong for us and will continue to be strong for us. But we're growing in areas where I mentioned kind of in aging as well, specifically disability and functioning long-term care. We have emerging evidence in sort of the whole health, it's a holistic picture of health that the VA has propagated throughout the whole healthcare system, and some of the new emerging areas in COVID and emergency medicine. So we haven't, we're serving our veterans, and we really view that veteran engagement is so critical to our research. And we've often included research advisory panels and veteran engagement panels, but we feel like this is really going to further improve our science. We've used it in different ways, mainly in proposal preparation, but we also want to have veteran engagement panels for some of our strategic planning as a center, some of our priority setting, and helping inform what might be best for dissemination activities where we haven't, received advice from veterans on that front before. It's also many funders and now VA funders are. It's actually a requirement, and it's being sort of scored on our proposals. What is our plan for veteran engagement? So not only is it being responsive to our funders, but I think it's imperative that we further engage our veterans in how we conduct research. So I think that's it for me. I appreciate your time. I might have to run out early because I have clinic at the VA at 1 o'clock, so I apologize to Deb or anyone if I'm running out before you're done. Next is Dr. Shelley Johns.
Okay, well, hello everyone. Thanks for coming. I wanted to just give you a quick overview of some of the projects that we have going on with my team. In 2018, the Walther Cancer Foundation donated $14 million to build the supportive oncology research program here at IU. And I have been very fortunate to be selected as one of their endowed chairs. And so much of what you see today is thanks to the Walther Cancer Foundation for their generous funding. So this is the mission of my personal research program: to develop, test, and implement novel behavioral interventions to reduce cancer-related suffering for adults with cancer and their family caregivers. By suffering, I tend to focus mostly as a clinical psychologist on emotional and psychological suffering, as well as social functioning. I'm getting into financial suffering, as well as existential suffering. And most of the work that I do crosses the cancer care continuum, from people who are just starting treatment through cancer survivorship and all the way into end-of-life care. And my work focuses on people with all types of solid malignancies across stages. So I'll highlight just a few of the projects that are ongoing. So some of you have probably heard me talk about our Facing Fear study, which is funded by the National Cancer Institute. It's an R01. And the cool thing about this study is that we enrolled 390 breast cancer survivors in just about 20 months of active recruitment. And we did that because of many of the faces that Losee showed you earlier in terms of research staff professionals. My team is led by Kelly Norton, Senior Research Manager, and several other people that you saw pictures of as well. So far, we're a little bit more than 50% done with the study, and we're just starting the third year of it. And we have 96% retention so far. And I wanted to see, I don't know if you can see these lines very well. Ooh, something looks really funky on here that it didn't look like that on mine at home. But you can kind of see, this is fear of recurrence scores at baseline, and then all the way down on the right side of your slides, you can see what happened at the post-intervention assessment. So in this R01, we're comparing 3 different behavioral interventions: acceptance and commitment therapy, which is what I focus on, and then we're also comparing acceptance and commitment therapy, or ACT, to cognitive behavioral therapy, and then we also have a single session survivorship coaching intervention. So you can see the biggest drop was in the cognitive behavioral therapy group. which is what we expected. Acceptance commitment therapy is real close to that, and then a little bit of a decrease, not quite so much in the coaching group. What happened in the pilot is acceptance and commitment therapy had a little bit of a decrease at post-intervention, and then it really caught up, and it really was the superior intervention at the 6-month follow-up. So stay tuned. I hope to come back and tell you more what shows up as we keep analyzing. A second study is our Mosaic pilot, and you can see a picture of my collaborator here, who is a Regenstrief affiliated investigator. This is Dr. Evan Jordan. And what we're doing in this pilot, because there are not enough clinical psychologists in cancer centers across the country, we decided that what we wanted to do is to develop an app that's based on acceptance commitment therapy that we can provide to patients who, while they wait to get in to see me or someone like me, where we can do some brief coaching with them so that they can at least start to build some skills until they can get in to see a therapist. And this is really appropriate for people with mild levels of distress. And so this is a 3-phase pilot. We've completed the first phase, the app is built, and then we're launching the second phase right now, where breast cancer survivors will be testing out the app and giving us some feedback to further improve it. This study is related to emotional well-being and financial toxicity or financial burden in cancer survivors. The cost of cancer care has exploded in recent years. Many of our patients are left in extreme financial distress. And so what we're trying to do in this study, we're attempting to enroll 200 adults with cancer to assess kind of how they're coping with with economic distress. My collaborator here is Dr. Catherine Mosier, who is also one of our affiliated scientists in the Center for Health Services Research. And you've also seen Eric Vachon's picture. I think Dr. Haggstrom had shown you Eric's picture before. Eric and I are also doing a large survey study as part of the IU Simon Comprehensive Cancer Center's catchment area. The Cancer Center has to, every 2 years, do a big assessment. And so Eric and I are leading a survey where we're hoping to get about 1,000 cancer survivors throughout the state of Indiana to basically tell us what needs they have, what are some of the challenges that they face, so that then we can begin to build programs to address some of these needs. And we are starting recruitment next month, we hope. And then I also wanted to tell you about a study that is not funded yet, but we've heard that it's probably going to be funded. This was a pilot grant that came out through the IU Simon Comprehensive Cancer Center. And we call this our Thrive Now study. It's a DEI-focused study where we are trying to develop a weight loss intervention for Black or African American breast cancer survivors whose needs have been very poorly met in the healthcare system in terms of weight loss and obesity treatment. And I say that it's not funded yet, but I hear through the grapevine that Misty and I may be funded very soon. So I just wanted to let you know that this study is coming up. And I also wanted to give a big thank you to Dr. Rich Holden, because I wouldn't know Misty Hawkins, my collaborator, without Dr. Holden. And he also was the big matchmaker who set me up with Evan Jordan for our Mosaic study. So a little cross-center collaboration there with Rich. And then finally, I wanted to mention an R34 application that is routing, this Friday. And the reason why I bring this up is because I love my collaborations with my colleagues in IU CAR. So you can see Dr. Susan Hickman and Dr. Kristen Lavoie here. They are key collaborators with this grant application. And this one is to support advanced care planning and to reduce barriers to advanced care planning using a mindfulness-based intervention. And this is a DEI-focused study as well, because we submitted this as an R01 earlier this year, and it got good scores, except they said they don't think it's going to work with Black or Hispanic survivors. And so this R34 will help us to be able to engage with cancer survivors who identify as Black and or Hispanic, to help them, so that they can help us to refine our intervention to be more culturally sensitive. So I think that's all I was going to talk about today, and I'm going to pitch to Teresa Damish, who is online.
Thanks, Shelley. And good afternoon, everybody. I am one of the co-PIs of the Extend Query Center. And for those of you who've been around for a while, we used to be the Stroke Query until 2015, where the VA decided they no longer wanted disease-focused centers, but centers focused on priority areas. And so 2019, based on our collaborations with our partners who identified telehealth service delivery models as one of their priority areas, we evolved into the Extend Query Center. And this was before the pandemic, I would say. So it turned out to be the right direction. Next slide, please. Thank you, Lori. Sorry about that. And the structure of our center is that we have 4 co-PIs. You've heard about Dr. Bravata, Dr. Williams, but this iteration we've been joined by Dr. Alan McGuire, who is a VA clinical psychologist and implementation scientist. We have an annual budget of over $1 million for 5 years, and we have a portfolio of projects. Next slide, please. Our projects span locally. TeleGrace is based in the Veterans Health Indiana healthcare system. And then our other 2 projects span the VA nationally. So Dr. Williams leads the teleneurology program, which provides outpatient post-stroke management. And also Dr. McGuire, he leads the implementation of cognitive behavioral therapy designed specifically for patients with chronic headache. And that is being implemented through the VA National Headache Centers of Excellence, which span the US as well. Next slide, please. Okay, so our anticipated program impacts is to expand veteran access to evidence-based care via telehealth services. And as well, we have an implementation science core that I lead, and we aim to identify and apply effective implementation strategy bundles and models of telehealth that directly improve the quality of VA care. And also we are looking at maintenance strategies of these telehealth practices. Next slide, please. So Dr. Bravata leads our TeleGrace project, and it is known as a hybrid virtual home visit. For those of you, again, who've been around, Steve Council had developed the GRACE program, the award-winning GRACE program, and Kathy Schubert directs that program over at the Roudebush VA. So Kathy is collaborating with Dawn, and they developed this TeleGrace program, and it's being tested right now in the Roudebush VA and in the rural communities about 40 miles from the VA hospital to expand services. And it's hybrid because the nurse and social worker dyad are based at the hospital, and a health technician goes out to the veteran's home, and together through virtual technology, they conduct the home assessment. Next slide, please. And these are 6 areas that for which barriers have arisen that needed problem solving as they have been piloting the TeleGrace program, and including telehealth connectivity and engagement, the virtual physical examination. It's done in combination with the technician, with the clinicians at the hospital, modifying protocols and procedures for this process. Staff training was a very important process. identifying, which patients this is appropriate for. And I think one of the more important implementation factors is team integration, because in the GRACE model, they have these dyads who've been working together for a long time. And now the telegrace model introduces a third. So they went from dyads to triads. And so this team integration is an important part of the implementation process. Next slide, please. Okay, and preliminary data has shown that our veterans have high acceptability of the telegrace program, saying that one veteran saying they don't know of any other program like this in the country where you get this type of follow-up. And the communication through the virtual visit has been fine, and that the veterans report that they're very comfortable, with the technology and the visits as well. Next slide, please. Our next project that I'm presenting is the implementation of cognitive behavioral therapy for veterans with chronic headache. And in 2019, Congress had awarded the VA with headache national centers of excellence based on the prevalence of chronic headache that follows veterans from active duty crossing over to their lives after they are removed from service and into the VA. And so a subset of psychologists were trained in this protocol, and they are based over at 9 facilities. And so this program was to facilitate the implementation of the protocol so that they can reach as many veterans as possible. So Alan's group implemented an implementation bundle of audit and feedback, external facilitation, and a community of practice. And these were to address some of the barriers that were known, such as inconsistent documentation, psychologists not seeing their data of how many veterans are seen, et cetera. External facilitation, one of the directors of the headache center said they appreciated the external facilitation because it kept their clinicians accountable. And the community practice was to share best practices across the psychologists across the country. And they reported that they found that very helpful to hear what was being implemented by their peers. Next slide. And this is just an example of one of the audit and feedback reports. This is reach across the sites, and also they're tracked by the different clinicians. But as you can see, there's such diversity in the implementation across the sites. Some are doing very well. Some need more resources, more facilitation to get their program off the ground. Next slide, please. Okay, and our final program in our portfolio is the National Teleneurology Program, and this is specifically for outpatient care. And Linda Williams leads that with the clinical director, Jane Wilkinson, who's based at the Philadelphia VA. And this program was born out of the general shortage of neurologists in general, both in the VA and outside the VA as well. And so the result is that there's poor access for veterans who need outpatient follow-up care. And especially in the rural areas as well. Not only is there a shortage of VA neurologists, but often there's very little choices for neurology services in the community. Next slide, please. So the telehealth service was born out of that, designed to promote these hubs of neurologists that can provide virtual outpatient clinic care. And so they distributed them, regionally, and they also used it as a recruiting tool to get neurologists in the VA. Next slide, please. And I believe Dr. Williams had presented on the teleneurology model about a year or two ago at Regenstrief, but as David said We just had a re-aim evaluation of the implementation of teleneurology accepted into Frontiers Implementation Science Special Journal. And what we've been showing is that that the teleneurology has been able to grow its program. They're reaching almost 60% of the veterans in the rural communities. They are setting up some services that cross into the suburban areas as well. The veterans report high satisfaction, and so do the primary care providers. The primary care providers are the ones who place the consults for the teleneurologist, and both groups report high satisfaction. There's multiple models of the telehealth. There is what was called VVC, and that's direct to the veteran home wherever they are with the provider. But the CVT is clinic virtual telehealth, and that is when the veteran goes to the outpatient clinics, often in the rural communities, and gets set up in a room, and the neurologist is still virtual. So in that virtual hub, like if they're in Chicago, they would have an appointment with the patient, maybe in West Texas somewhere. And so there's two models that they've set up the teleneurology program. And satisfaction was the same, whether it's direct to the patient home or to the clinic. But the only difference was that the veterans who get virtual care directly to their home said they don't have to drive like 100 miles to go see a clinician, and that they appreciate it very much. Let's see here. And there were implementation barriers, but also implementation success of the program. In the next slide, I'm just going to elaborate what are some of the successes of the program based on the leadership. Next slide, please. And the National Teleneurology leadership said that they will not engage and set up in a site unless they absolutely get buy-in from the facility leadership. And this is, the chief of staff, the medical director. They also collaborate at the middle management level with the general practice managers and setting up these virtual embedded clinics so that the primary care doctors, that it seems like the teleneurologist is part of their local system, and where they can, their schedules are local also at these rural sites. So they established a clinic at these sites, and for the most part, it's the same teleneurologist assigned to each of the different sites and the different clinics, again, so that continuity, so that they are seen as part of the local context as also like a local provider. Through Microsoft Teams, which is, some you may or may not know, is a secure way of communicating. The National Teleneurology Program has created these channels, these communication channels, so that the teleneurologist can talk directly to any of the primary care providers and vice versa. So it's we can identify problems, but also have discussions on how to solve them. And then the national program has been purposeful in developing this national cohort of virtual teleneurologists. They actually believe it's a great recruiting tool that for folks who like to work through telehealth, that they have put together a growing body of virtual clinicians, and they also foster a sense of team and professional development. And they are, from our data, they're quite happy with their workforce and work situation. Next slide, please. And these are just briefly our future directions. We are currently in the planning phase. A year from now, we'll have to resubmit our next center iteration. So we're meeting with operational partners and understanding where we want to go next. Again, taking a look, some of the conversations are about how do we sustain these telehealth models, and some cross-query themes that we're dealing with are adaptations, and how that impacts implementation. Workforce, we hear this across the disciplines. Burnout from primary care, nursing to specialty care. Burnout is real, and how to deal with the workforce. And then also there's just been a minority of perceptions, but from both providers and patients, no matter how much technology or how well their telehealth visits have gone, there are some who believe that they must be physically touched in an examination in order for them to feel that it's been effective. So I just wanted to say that these are some of the themes that we've emerged, and this is our work that we're doing. So thank you very much.
Thank you, Teresa.
Well, thank you all for sticking this out. It's been a tasting test here. And we are a little behind, so I had 7 minutes, but I'll do 5 minutes and then we'll close out for the day. But I was asked to talk a little bit about the We Care program, and so I will do that in rapid speed. Want to acknowledge the large team that works with me, and this is just the Regenstrief side. There are others at our other partnership sites as well. And advance. So again, some of these slides are a recap of some of the data I've shown previously in terms of where we've been, but the infant mortality rates still remain a huge concern in the state of Indiana compared to the United States and Marion County in particular, where the infant mortality rates still remain much higher than the rest of the state. And also in particularly twice a problem for our African American population than our white. So we went to work many years ago now on the We Care project to target mutable behavioral changes that could impact infant mortality, and they're listed there, those target risk behaviors, as well as social determinants of health that are the health influencers that affect many diseases, including infant and maternal mortality. And our effector arm are our amazing community health workers who we train, hire, deploy, and supervise. And also they are our research assistants in that they are trained to collect data and do an amazing amount of collection for us that's with high fidelity. They're supported well by educational materials and a process of bidirectional messaging and so forth that we've evolved over the years, and as well as weekly management case conferences and peer support. Lots of detail that I won't go into. But we targeted the 13 highest risk zip codes for infant mortality years ago. Those still remain pretty much the same. They were mapped to the 17 federally qualified health centers of the 2 health systems we worked with originally, Eskenazi and HealthNet, as well as a little sampling of some of the other smaller private religious affiliated or community-based centers, and continue to work with many of them. We targeted women of reproductive age, both pregnant and postpartum mainly, and the age groups, as you expected, were mostly 18 to 35, but they also had some teens and some women in the older reproductive age group. But again, targeting specifically for our women of color, particularly women who are Black or biracial, and we had a significantly higher percentage of those women enrolled in our study. The outcomes were published in 2022 for the first round of data. We were able to show that there was statistical improvement in all of those with a little asterisk in terms of the behavioral changes compared to baseline for mental health, reduction in substance use, use of WIC, which was an indicator of our food insecurity issues, couldn't budge smoking, which isn't necessarily a surprise, safe sleep, and breastfeeding, all of which were known to be independent risk factors for infant mortality. And most importantly, we were able to show in terms of the major impact that we saw in the We Care group compared to Marion County Central region, again, where you saw that the majority of deaths were occurring, and compared to the state, that our women were having less IMR, infant mortality rate, as well as lower infant mortality, or low birth weight rather. So those data continue to be collected and compared. But our next challenge was, okay, well, if we can show these changes in a federally qualified health center population in terms of implementation rollout, where else might we show an impact? And it was about that time we were up for renewal for funding from the State Department of Health, and we were able to get an extension grant. And IU Health approached us to become a partner. And so we are now, therefore, working with them, with 6 community health workers in the yellow zones here, the central region as well, working in 6 other clinics that are IU Health clinics, and are quite excited about our partnership that's evolving and growing with them as they do significant work in the area of maternal and infant risk reduction. And they involve clinics that are really drawing very high-risk women of a different, probably demographic and etiology in terms of the maternal fetal high-risk clinics at the Coleman Center and also at Riley. So we have new challenges to look at and new risk factors and a combination now of both our social behavioral and social determinants of health risk factors along with biomedical, which will be interesting to see how much impact we can have when we have such complicated comorbidities. The other area of gap that we thought in terms of our implementation work was to really think about the problem of our large population of women of childbearing age who also had substance use disorders. So several years ago, we received a grant from the IU Addiction Grant Challenge Initiative to think and evaluate that group, and added to our We Care team the CARE group, which are the addiction recovery coaches who are also dual certified as We Care coaches. And Gloria Haynes, you might recognize her, is one of our Regenstrief employees who's done a remarkable job in the area of recruiting women from the prisons once they're released, and for many of our recovery centers around the city, like VOA, where women with substance use disorder can be enrolled in their recovery programs along with their children. So we have quite another population to examine, explore, and to provide supports and see if it can make a difference. This is some of our latest research, just to give you a little taste test again. In terms of our CARE program, we've worked with several of the IMPRES students over the last several summers, and they've done remarkable work with the team. This one is Anastia's work that will be presented at the HEAL conference here in November, just in town, where we were able to show that looking at racial differences of the women in the CARE program, those with substance use disorder, white women were more often, statistically more often, to be in treatment and on medical assistant treatment at the time of entry into the study, and were more motivated for staying in treatment based on a validated scale. However, at 2, 6, and 9 months, Black women were statistically significantly more often retained in the program. That was, again, a peer addiction recovery coach, recovery coach, a synonymous terminology here, providing care and doing the interventions in the community away from the stigmatized medical sites that many of the women don't go to. And they were providing all the kinds of supportive care there that is consonant with our qualitative research that we believe is really making a difference in terms of encouraging women of color to stay in some supportive care and encouraged to get behavioral health care, medical assisted treatment on Suboxone and other things that will really make a difference. So that's exciting to be able to present that. This is just a very quick look at some of the work that the trainees have done with our qualitative work in terms of facilitators and barriers to staying in our treatment programs. And the take home here is that community health workers were on many of our things, the most important facilitators for staying in treatment, and lots of different challenges were had. But the last thing I'll highlight here is our most recent work, which is in the area of policy, an area that I hadn't previously worked in before getting into this arena, and looking toward sustainable models of funding for community health workers is a major issue. We know from all of our research that community health workers can make a difference in social determinants of health. They make a difference in medical outcomes in many areas, including infant mortality, diabetes, cardiovascular disease, advanced care planning, et cetera, et cetera. The ROI studies have shown that they decrease hospitalizations and ER visits. But in the state of Indiana, in terms of Medicaid reimbursement for fee-for-service, the reimbursement rates, as you can see on this map, I hope, is $9.70 for a half hour of face-to-face time. It's the lowest in the country, only equal to Kansas. So we are working hard, along with several people in this room, to do a deeper dive into the models of care and working closely with FSSA and the Medicaid policy developers to work on state plan amendments and looking at other models of care, such as managed care, value-based processes of care, and hub models and other kinds of reimbursement schema that are being used around the country, so that we can convince the state they need to do a better job. This work is being presented at the American Public Health Association next month too by a couple of our Regenstrief in-press students, so we're excited about all this. And there's lots of people who help fund this, so nods to all of them. So David, shall I give you a closing word?
So I'm very inspired by all the work described here, so I hope you've enjoyed it as well. I go away motivated. Please approach me or any of the panelists in the future if you'd like to learn more about their work. I think we have so much to learn from each other in terms of our research, our methods, as well as to have impact and reach upon very challenging and difficult problems that we care about. So thank you all for hanging in with us. Have a good afternoon.